a colleague who told me that he believes his patient's lungs are fans of Boys to Men. I said, huh? How's he talking, man? He said, no. When he was auscultating the patient's lungs, he heard the left lung singing to the right lung. We belong together. And then it so happened that same patient had a pleural effusion. When he listened inferiorly over the effusion, he heard, take my breath away. Hello everybody, it's Ryan here. Today we're discussing our beloved pleural effusion. I hope you and your family are well. We're going to be covering a clinical case and then breaking down pleural effusion in terms of etiologies, pathophysiology, investigations and management, and of course talk a bit from the Bible thereafter. Here's our handy clinical case. Alrighty, let me get my yeah. So you admit, let's make it Mrs. Pleurodesis with severe community-acquired pneumonia who requires intubation and mechanical ventilation. Damn, that was a bad pneumonia. She has decreased breath sounds and dullness to percussion halfway up her right lung. Chest X-ray and ultrasound to confirm the presence of a large pleural effusion. You perform a diagnostic thoracentesis, which is a fancy way of saying pleural tap. But alas, the fluid remains. Now, all of the following are indications for complete drainage of pleural fluid with one exception. What is that exception? Is it A, a pleural fluid pH below 7? Is it B, pleural fluid glucose below 2.2 millimole per liter? Is it C, pleural fluid protein to serum protein above 0.5? D, pleural fluid LDH above 1,000 units? Or is it E, bacteria either seen or cultured from the pleural fluid? What is a pleural effusion, guys? It refers to the accumulation of an excessive amount of fluid in the pleural cavity. And please note the following points, right? Now, between the visceral and the parietal pleura is a potential space which normally has at least 5 to 15 moles of fluid clinically. Now, in order to detect pleural effusion clinically with the stony dullness and the diminished intensity breath sounds, you need at least 500 moles of fluid to have accumulated. To detect pleural effusion on a chest X-ray on a PA film, you need at least 200 moles of pleural fluid. To detect it on a lateral decubitus film, you need at least 100 moles. Ultrasound is very sensitive and can even pick up even small amounts, like even 20 to 25 moles upwards, right? So, in essence, normal is 5 to 15 moles. Ultrasound can detect up to 20 to 25 moles upwards. Lateral decubitus, chest X-ray, 100 moles. PA, chest X-ray, 200 moles. And to detect it clinically, you must have a significant effusion, at least 500 moles, right? So here's a picture of a beautiful left-sided pleural effusion on a PA chest X-ray. We can appreciate there's a blunting of that costophrenic angle on the left with a meniscus sign. So that's definitely fluid. Speaking to a pleural effusion, here's a bilateral pleural effusion. Guys, what are the causes of dullness to percussion on the left, over the lower chest? All right, so it can be, if it's stony dull, you're thinking pleural effusion, right? It could be thickened pleura. It could be consolidation if it's woody dull. It could speak to collapse of the lung or a raised right hemidiaphragm. If that be the case, think about hepatomegaly or the liver being pushed up, or it could be an underlying mass lesion. Now, what are the definitive signs, clinically speaking, for a pleural effusion? Well, stony dullness is one which is going to be confirmed by aspiration. So stony dullness with reduced to absent breath sounds. Over the upper part of the effusion, you may hear bronchial breathing, okay? How do we confirm the presence of a small effusion? Well, there's three things you can do, right? If you're in a resource-limited setting, you can do an X-ray in the lateral decubitus position, and that fluid is going to redistribute because of gravity, right? And you'll see that. We'll see an example just now. You can do ultrasound of the lower chest. We said it's sensitive to even small amounts of fluid, between 20 to 25 moles upwards, occasionally CT scan of the chest. And this is the lateral decubitus film, which is showing us exactly what we were talking about. You've got a right-sided effusion, okay? But with the posture, you ask the patient to go into the lateral decubitus position, that fluid is going to redistribute because of gravity. And that is a nice way to confirm whether, on the pacification, which you think is an effusion, is actually an effusion, or whether it's a consolidation, because consolidation would not cause redistribution of fluid, as would a pleural effusion in this case. Alrighty. Now, I'm sure all of us have encountered this scenario. If you clinically detect the pleural effusion, there's dullness from percussion, diminished intensity breath sounds on that side. But when you do the pleural tap, no fluid is coming out. What's the possibilities? It could be a thickened pleura, number one. The fluid may be just too thick or viscous or tenacious, speaking to an empyema. It could be a mass lesion, right? Mentioned causes are predominantly right-sided pleural effusion. They think about anatomically speaking, the liver is there. So liver abscess, it could be Meags syndrome coming from an ovarian fibroma. It could be dengue hemorrhagic fever. Don't forget heart failure. Heart failure is normally bilateral, but the thinking is more on the right than on the left, because what happens is that because patients with heart failure have some degree of cardiomyopathy, and when they're sleeping on the left, they get palpitations. So they'd rather sleep on the right, and because of the dependency on the right, they tend to accumulate effusions on the right side preferentially. That's just the theory, guys. What are the causes of a left-sided pleural effusion? Well, acute pancreatitis, rheumatoid arthritis, Dressler syndrome, which happens a couple of weeks after an MI, esophageal rupture in the way of Boerhaave syndrome, dissecting aneurysm. Right? What are the different types of pleural effusion according to color? We see some delicious pleural effusion. If it's serous, not serious, it's serous, speaks to hydrothorax. Okay, so this is serous, think hydrothorax. If it's straw colored, you're thinking, oh, okay, it could be tuberculous. If it's purulent, right, yucky purulent, you're thinking about empyema or pyothorax. If it's hemorrhagic, you're thinking of hemothorax. If it's milky or chylous, you're thinking of chylothorax, alrighty. Okay, what are the relevant findings that can help determine the cause of a pleural effusion? Well, that's a lot of things to talk about because the differential for pleural effusion is quite broad. So if there's concomitant edema, you're thinking about hypoalbuminemia, which can come from a variety of diagnoses. It could be nephrotic syndrome, it could be hypothyroidism, it could be protein-losing enteropathy, it could be chronic liver disease, right? If the patient's emaciated, you're thinking TB or malignancy. If the patient looks malnourished, it may be due to hypoalbuminemia. If there's concomitant lymph nodes, you think, okay, lymphoma. If there's clubbing or nicotine staining or radiation mark, you're thinking bronchial carcinoma. Signs of rheumatoid arthritis or SLE, that portends those particular diagnoses. So you might have chronic liver disease, there you go. Signs of congestive heart failure and mixed edema. How do we investigate a pleural effusion? So first up, you want to do a chest X-ray PA film. If it's a small effusion, you do a lateral decubitus film, right? But we said if at least 200 moles of fluid is there, you should see it on a chest X-ray PA view. Do a full blood count for the ESR. A high ESR speaks to TB, leukocytosis in the context of pneumonia. You may want to do a MEN2 or a tuberculin skin test. Right, and then of course, I mean, the money-throwing investigation is a pleural tap or a trachocentesis, right? You're going to send that fluid off. Firstly, look at the physical appearance, like we saw a couple of pictures. Is it straw-colored? Is it serous? Is it hemorrhagic? Is it chylous? Then you do a gram stain in cytology, which is routine. Otherwise, you're going to miss a malignancy. And send off for exfoliative cytology, where they look at malignant cells. Send off for biochemistry, looking at the protein and the glucose. We're going to talk about Light's criteria just now. Also, do your serum glucose, protein, and LDH, so you can actually compute the Light's criteria. ADA for adenosine deaminase, especially in our setting here in sub-Saharan Africa, because TB is endemic. Pleural fluid culture and sensitivity, good idea. AFB in some cases, mycobacterial culture. You can actually inoculate a culture bottle with the pleural fluid. Other tests to consider in special scenarios: cholesterol, LDH. Well, LDH is part of Light's criteria. That should be a standard. And rheumatoid factor. Amylase, if you're thinking acute pancreatitis, because amylase is high in acute pancreatitis. Esophageal rupture and malignancy. Triglyceride, if you're thinking about chylothorax, right? Okay, this is a lovely cartoon from MedComic.com. Thank you so much, Mr. George Muniz, looking at pleural effusion. So we said, yeah, let's just get our pointer in there. Accumulation of fluid in the pleural space. It's broadly categorized in terms of being transudative or exudative, right? And we look at the Light's criteria just now. But if it's transudative, that speaks to increased hydrostatic pressure or low plasma oncotic pressure. If we look at Starling's forces, and that underpins the pathobiology of pleural effusion, right? Examples of transudative causes of pleural effusion: congestive heart failure, cirrhosis, nephrotic syndrome, pulmonary embolus, hypoalbuminemia. So transudate is low in protein and LDH, right? But exudates of pleural effusion occurs in inflammation and increased capillary permeability, which is high in protein and LDH. And classic examples: TB, and more TB, cancer, pneumonia, viral infection. Pulmonary embolus can go either way, right? And autoimmune phenomenology, right? So what investigations? We're continuing with this question. Number 7, other investigations as per suspicion of the cause. So if you're thinking of an autoimmune problem, if there's other stigmata of autoimmune disease, right, then you're thinking about doing the necessary antibodies, anti-nuclear factor, anti-double-stranded DNA in SLE, liver function test if there's stigmata of chronic liver disease, urine for protein and serum total protein, you can compute your albumin to globulin ratio in nephrotic syndrome. If there's palpable lymph nodes, do a FNAC, which is a fine needle aspirate, or do a formal biopsy and look at the histology. Is this lymphoma? Are these Mets? And then, of course, CT scan in some cases already. So guys, what is the role of pleural fluid amylase? Pleural fluid amylase may be higher than serum amylase in the setting of acute pancreatitis, bacterial pneumonia, esophageal rupture, and malignancy. But the main reason why we want to compute this is when we're thinking about acute pancreatitis, right? It is also high in adenocarcinoma of the lung and may be useful in differentiating this from mesothelioma, right? Okay, so this is taken from Harrison's, and we're looking here at diagnostic algorithm for a pleural effusion. So let's just say there's a pleural effusion. You perform your pleural tap, you measure your pleural fluid protein LDH. Then you look at Lyle's criteria. If the pleural fluid protein to the serum protein is above 0.5, if the pleural fluid LDH compared to the serum LDH is above 0.6, and if the pleural fluid LDH, which is lactate dehydrogenase, is above 2/3 the upper limit of the serum normal, then this is an exudate, right? And then we talked about exudate, and you go through the necessary investigations. Or if this is untrue, then it's transudate. Then you treat the heart failure, cirrhosis, or nephrotic syndrome. Okay. You can also measure the pleural fluid glucose, obtain pleural fluid cytology, do a differential count, send for culture, and look for ADA, do your gene expert. If your glucose is low, these are the causes of pleural effusion with low glucose, guys. Malignancy, bacterial infection, rheumatoid, pruritus. If pleural tap doesn't give you any answers, then you want to consider pulmonary embolus. You can do your D-dimer, do your ECG for signs of right ventricular strain, S1Q3T3, etc. Do your echo, look for signs of pulmonary hypertension or stigmata of pulmonary hypertension, measure those pulmonary pressures. If indeed, then those are positive, do a VQ scan or a CCPA and treat your pulmonary embolus. If there's peripheral markers positive for TB, treat the TB. If the symptoms are improving, you simply observe. If all your investigations doesn't yield anything, then you want to consider thoracoscopy and image-guided pleural biopsy. Thank you so much, Harrison. This is the last criteria in context. So you do your pleural tap, like we said, and you're going to measure your pleural fluid protein compared to the serum protein. If it is above 0.5, it's an exudate. Below 0.5, transudate. Then you look at the LDH in the pleural fluid compared to the serum. If it's less than 0.6, it's a transudate. More than 0.6, exudate. And you look at the plasma LDH being less than 2/3 upper limit of normal. If that be the case, then that's a transudate. If not, then that's an exudate. And common causes of transudate, like we mentioned, hyperapnea from any source, be it cirrhosis or nephrotic syndrome, congestive heart failure, constrictive pericarditis. Remember, a big tip-off for constrictive pericarditis, we said in the video on constrictive pericarditis, if you have ascites out of keeping with peripheral edema, that's a tip-off for constrictive pericarditis. Exudative causes range from autoimmune disease to esophageal rupture to infection, TB, fungal, empyema, parapnemonic, malignancy, pancreatitis, post-coronary artery bypass graft, pulmonary embolus. What are the causes of a high eosinophil count in pleural fluid, which is also high in the blood? So here we're thinking about pulmonary eosinophilia, polyarteritis nodosa, and very rarely lymphedema, which gives you high eosinophils in the pleural fluid, but not in the blood. And if indeed it is not high in the blood, but high eosinophils in the pleural fluid, you're thinking about pulmonary embolus, right? High eosinophils in pleural fluid is unlikely to be malignant. What is pseudotumour, otherwise termed phantom tumor? Refers to the accumulation of fluid in the interlobular fissure, usually found along the lateral chest wall. Now, chest X-ray shows a rounded, homogeneous opacification which looks localized or like an assisted effusion. Often this is misdiagnosed as a tumor. It is confirmed by ultrasound or CT scan, disappears with resolution of the effusion, commonly found in congestive heart failure. What is yellow nail syndrome? It's a congenital disorder characterized by nails which are yellow and thick and concomitant onycholysis. We also have lymphedema of the legs, and we have pleural effusions or bronchiectasis, right? And there's a beautiful picture of some yellow nails, nice and yellow. Get in there. What are the features of a parapnemonic effusion? How do you treat a parapnemonic effusion? Well, parapnemonic effusions are usually small and localized. They may be non-infected or have infected fluid. Essentially, any loculated effusion is highly suggestive of empyema. The way you treat it is, if it's uncomplicated, then you just give antibiotic. But if it's complicated parapnemonic effusion, put in an intercostal chest drain or what they call a chest tube, should be inserted in the following circumstances. If there's gross pus, if there's gram stain of the fluid which yields positive organisms, if there's a low glucose and the pH is below 7, that speaks to empyema. Now, if the pleural fluid is indeed loculated and not adequately drained, you can give streptokinase injection about 250,000 units, should be injected intrapleurally to dissolve that fibrinous membrane. If still inadequate drainage, thoracoscopy with breakdown of adhesions or thoracotomy with decortication, send the patient to cardiothoracics for that. Now, when are you going to suspect a malignant effusion? So, if you've got an elderly emaciated patient, if you've got the presence of generalized clubbing is a big tip-off that, hey, this could be bronchial CA and nicotine staining, especially in smokers, right? But remember, COPD should not give you a pleural effusion. But if you have COPD in a smoker who has clubbing, you're thinking about a malignancy, right, with a pleural effusion. Palpable lymph node, radiation mark in the chest, pleural fluid being hemorrhagic, rapid accumulation after aspiration, all of those are telltale signs that, hey, you could be dealing with a malignant pleural effusion. What are the causes of hemothorax or chest injury or trauma? Probably the most common. Bronchial carcinoma, pleural mesothelioma, pulmonary infarct, other causes like SLE, lymphoma, acute pancreatitis. What is empyema? Causes of empyema. It refers to accumulation of pus, right? Frank pus, pus in the pleural cavity, right? Causes could be tubercular or non-tubercular. If it's non-tubercular, it happens in the clinical context of bacterial pneumonia, lung abscess, bursting in the pleural cavity. So the patient has halitosis and clubbing. That's a case of suppurative lung disease. Bronchiectasis, secondary infection post-aspiration, rupture of a subphrenic abscess or liver abscess, and infected hemothorax. How do we diagnose empyema thoracis clinically? Good question. Well, on the symptoms, the patient often has high swinging fever associated with chills, rigors, and sweating. Fever is persistent even with antibiotic. You have malaise and weight loss, copious purulent sputum if the empyema ruptures into a bronchus, causing what we term a bronchopleural fistula. Signs are that the patient is toxic and emaciated, tachypnic and tachycardic, has clubbing, and you want to do an aspiration, which is going to show pus or purulent fluid. How are we going to treat empyema thoracis? Well, if it's non-tuberculous, you drain the pus, intercostal chest drain, but it's the antibiotic for 2 to 6 weeks. A common choice is coamoxiclav, which is Augmentin, or cefuroxime plus metronidazole, and of course you tailor that as per cost and sensitivity of pleural fluid, right? If it's tuberculous empyema, it is a wide bore needle aspiration or intercostal chest tube, anti-TB therapy, right? For at least 6 months. So 2 months intensive, 4 months continuation, sometimes surgical ablation of those pleura. What is empyema necessitans? Yes, it's necessary for us. It's necessary. Ha ha ha. In empyema thoracis, the fluid may come out subcutaneously into the chest wall. And this is what we call empyema necessitans. What are the causes of bilateral pleural effusion? Essentially all causes of effusion which are transliterative. So we're shedding some light on this one with Light's criteria, right? So if it's transidative, which means P5L6, yeah, so your pleural fluid protein compared to the serum protein less than 0.5, pleural fluid LDH compared to serum LDH less than 0.6, pleural fluid LDH less than 2/3 the upper limit of normal for serum LDH. Consider congestive heart failure, nephrotic syndrome, liver cirrhosis, malabsorption, malnutrition, hypoproteinemia. All of these cause bilateral pleural effusion, together with other things like collagen disease, rheumatoid arthritis, SLE, lymphoma, bilateral extensive TB, pulmonary infarct, and malignancy. So these are the so-called exudative causes of bilateral pleural effusion. But often bilateral effusions happen in the context of transudative etiologies, right? And if it be a malignancy, then it's usually multiple mets involving both lungs. What's the mechanism of tuberculous pleural effusion? Quite common in our setting. It's because of hypersensitivity to the tuberculous protein in the pleural space, right? What are the causes of recurrent pleural effusion? How do you approach treatment? So bronchial carcinoma, pleural mesothelioma, so watch those asbestos workers, lymphoma, collagen disease in the way of SLE, all causes of transudate. We treat with pleurodesis. How do we go about doing pleurodesis? It's usually done by the cardiothoracic guys or the oncologists. So you place a rubber tube into the pleural space in the intercostal space, and fluid is removed as far as possible with aspiration. Then you administer a drug. It can be tetracycline or talc through the tube. You clamp it and you keep it in for 48 hours, sometimes, overnight. Now, in a malignant pleural effusion, you can also give a chemotherapeutic agent, commonly bleomycin, 30 to 60 milligrams. The patient's posture should be changed 2 hours later to allow the drug to spread nicely within the pleural space. After about 4 to 8 hours, you remove any remaining fluid and take out the drainage tube at the height of inspiration. Quite inspiring, huh? The patient usually complains of severe chest pain post-pleurodesis, so give adequate analgesia. What is chylothorax? Mentioned causes. So chylothorax is a milky or whitish fluid in the pleural cavity due to lymphatic injury or obstruction of the beloved thoracic duct. Causes can be traumatic in the setting of surgery and trauma, neoplastic in the way of bronchial cancer and metastases, infective TB commonly, and filariasis, which is caused by Wuchereria bancrofti. and lymphoma involving the thoracic duct. What's the mechanisms of pleural effusion? So it all has to do with the Starling forces operating across the capillary membrane. So excessive fluid accumulation occurs whenever the pleural fluid formation exceeds the absorption, or normal pleural fluid formation occurs with reduced absorption. Possible mechanisms are increased hydrostatic pressure, as in congestive heart failure, reduced plasma colon-cardiac pressure, as in hyperproteinemia from any cause, be it nephrotic syndrome, be it cirrhosis, be it protein-losing enteropathy, involvement of the pleura causing increased permeability, as in TB or malignancy, impaired lymphatic drainage of the pleural space, as an obstruction of the lymphatic system by tumor, TB, radiation, or it could be transdiaphragmatic passage of fluid, as in liver disease, ascites, acute pancreatitis. Don't forget with hemodialysis as well. So this is hemothorax. It's a beautiful image taken from Netters, right? So the sources of hemothorax can be the lung and the intercostal vessels, the internal thoracic being the internal mammary artery. It could be via a wound tract coming from the thoracoacromial artery, lateral thoracic artery, mediastinal great vessels, heart, and abdominal structure. So this is what hemothorax looks like in terms of different accumulation of fluid. So it can be up to 350 mils. If that be the case, the blood usually resorbs spontaneously with conservative management. You don't really need thoracocentesis. But if it's moderate hemothorax, 350 to 1,500 mils, you want to put in an ICD, right? If it's above 1,500 mils, 2 drainage tubes are inserted because one may coagulate. But immediate or early thoracotomy may be necessary to arrest bleeding. Okay, what are the features of a rheumatoid pleural effusion? It's common in males, occurs in upwards of 3% of cases of RA. Usually it's a small effusion, more on the left side, maybe bilateral. The pleural fluid is serous early on, but later can be turbid. It's never bloodstained unless traumatic, right? Rheumatoid factor usually positive with nodules present in the lung. Systemic features are prominent. And in terms of your pleural fluid study in the context of a rheumatoid pleural effusion, you're going to find the following, alrighty? It's usually exudated with a high protein and a low glucose. That is a tip-off. High cholesterol, the fluid looks turbid. You have a high LDH and low complement. Rheumatoid factor in the pleural fluid may be positive. Aha. In the fluid, you're going to find, histologically speaking, elongated macrophages, giant multinucleated macrophages, and few mesothelial cells. One of the features of tuberculous pleural effusion, it's straw or amber colored. It's exudative according to Lyse criteria. You have a high lymphocyte count in the pleural fluid. Acidophilus bacilli found in upwards of 20% of cases. Culture for AFBs positive in a third of cases. Pleural biopsy positive 80% of cases. Do your gene expert on the fluid as well. What are the indications for pleural fluid aspirations? You can do diagnostic and therapeutic. Diagnostic to see the physical characteristics of this pleural fluid. Send off for cytology, looking for polymorphs and lymphocytes. Exfoliative cytology, looking for malignant cells. Biochemistry, looking at your Lyse criteria with the protein, glucose, LDH. Do your adenosine deaminase for TB. Therapeutic, if the patient is respiratory distress or if this is a big old massive effusion. So how much pleural fluid can be drawn at a time? This is a beautiful question to ask. Usually up to 1,500 mils, which is 1.5 liters. If more is drawn, then there is a risk of re-expansion pulmonary edema, which is a reality. The mechanism is that due to an effusion, that lung is compressed and there is ischemia to the lung parenchyma and necrosis of pulmonary vessels. If more fluid is drawn, there's rapid expansion of the lung, sorry for the typo there, which occurs. As necrotic vessels have not yet regenerated, there is more leakage of fluid, which causes the re-expansion pulmonary edema. Any role for steroids in pleural effusion, usually given in the setting of tubercular pleural effusion, right? Although controversial, some evidence suggests that it promotes rapid reabsorption of pleural fluid, given the patient's quick symptomatic relief. Other things in TB, in which case you want to stick steroids on top of TB treatment, is TB pericarditis and TB meningitis, right? Giving steroids also prevents pleural fibrosis, thickening of the pleura, and adhesions. Steroids should be given or should be used along with anti-tubercular therapy in tapering doses. What is the problem with steroid therapy in the setting of tuberculous pleural effusion? Because steroids induce the synthesis of hepatic enzymes, which causes breakdown of rifampicin, so you may need to up-titrate your dose of rifampicin. Okay, my friends, let's get back to our clinical case. We had Mrs. Pleurodesis, right? Who comes in with community-acquired pneumonia. She's hypoxic. You intubate and ventilate her. She has diminished breath sounds and downless halfway up her right lung. X-ray and ultrasound confirm a large pleural effusion. You do a diagnostic pleural tap, but the fluid remains. So all of the following are indications for complete drainage of the fluid with an intercostal chest drain, with one exception. What is that exception? It is pleural fluids. Protein to serum protein of above 0.5. Right? So that's looking at exudate as per Lyse criteria. So Pleural effusion is a known complication of severe community-acquired pneumonia. Now, a significant pleural effusion should be tapped for both diagnostic and therapeutic purposes. If the pleural fluid grows bacteria or has pH below 7 or glucose below 2.2 or LDH above 1,000, then that speaks to it probably being an empyema, and that effusion should be completely drained with the intercostal chest tube, right? However, while pleural fluid protein is a vital component of Lyme's criteria and can determine if a effusion is a transidate or an exudate, there is no recommendation for complete drainage based solely on the pleural fluid protein result. Alrighty, so my friends, let's talk about answered prayer today from Scripture. The book of Jeremiah 33:3 says, God is saying, call to me and I will answer you and show you great and mighty things which you do not yet know. Psalm 91 verse 14 to 15, because he has set his love upon me. Right, therefore I will deliver him, I will set him on high, because he has known my name. He shall call upon me and I shall answer him. I will be with him in trouble. I will deliver and honor him. Prayer is so important, beloved. And I just encourage you to commit your request to God and seek his face. Know him and he will deliver you. He will undertake for you in your particular situation. Philippians 4:6 says, be anxious for nothing, but in all things through prayer and petition with thanksgiving make your request known unto the Lord. And then the peace of God, which transcends all human understanding, will guard your hearts and minds in Christ. I pray that upon you in Jesus' name. Thank you so much. These are my references. I will see you soon with another pulmonology topic coming soon to a channel near you. Internal medicine, algorithms, and mnemonics. God bless you. Have yourself a fantastic day. Take care.